Oh, first of all, it's a treat to be here because it's snowing in Boston right now, by the way. So I just wanted to let you know it's just, even to have rainy London is a real treat. So thank you for inviting me. And I think I was here for the first Pathways conference and several in between. And I think we've sort of all been growing together, but I've always found that when I come over here, I learn so much from the way your system works versus the way our system either works or doesn't work. So, today, what I want to share with you is, I think that's the last slide. Can you go to the first slide? I'd like to share with you our experience of housing really hardcore rough sleepers in Boston. It comes from, and just to give you a thing, so my life for the last 35 years, because of the way things happen in Boston, is I've been a full-time doctor taking care of homeless people in Boston with a team, and it's probably the best job I could ever imagine. I thought I'd do it for 6 months a year, and I'm still doing it all this time. But it's because of the team I get to work at. But let's go, I can control the slides, huh? Can I do that? So the question that we've been asking, and I think Jennifer put it all together so nicely, that there's a lot about housing first and permanent supportive housing that just is the right thing to do. People deserve it. It should be a right of everyone. But there's a lot of questions about how to do it, like what types of housing, what types of supports, all of that stuff. And I think that's the dynamic and the conversation that we have to have. But what happens to rough sleepers in particular? Now, this is just looking at hardcore rough sleepers, okay? And in our case, we started housing, the people we're talking about are people that had lived at least 5 years consistently on the streets of Boston and then were placed in housing. But our program goes back to 1985. It was a grant. I just wanted to tell you, so, and this is all boring, but basically we've grown in ways I hadn't expected. We thought, as somebody mentioned earlier today, that we were just an emergency setup. We were going to all be in other jobs after 4 or 5 years. It didn't turn out that way. But some of the things that we've learned, we have clinics at most of the shelters in town that are run by our doctors, nurse practitioners, social workers, community health workers. And we were also told by the people that put us together, which were homeless people, that we had to start respite programs back in 1985. So we've been sort of slowly evolving a respite program where, I don't know if I have a picture of it, I don't, but we now have 104 beds in a big building across the street from the hospital, which looks like a step-down hospital with full doctors, nurses around the clock, psychiatrists, social workers, benefits workers. And now we also have another 20-bed unit, which is a more step-down one. So we have about 124 beds of respite care in Boston, and believe it or not, always full, and we could probably use about 3 times as many beds. But anyway, today, this is a group, this is a picture that I promised somebody that I'd show all the time. It was taken by a homeless woman of some homeless guys. Actually, there is one woman there as well, but she's hiding. That was taken back in the year, just in 1999, just before the year 2000. And it was the picture that sort of crystallized things for us, because we knew all those folks. They were all people we took care of. They were, as you might expect, colorful, exasperating, charming, just the best. But we knew their whole stories. And when I looked at this picture, I didn't see it till 5 years later when she gave it to me. She was going into surgery, and she had taken it with a throwaway camera, and she asked me if I'd hold on to it. So I'm looking at that picture and realizing that this is America now, so you have to realize we have probably the most unjust healthcare system in the world, where you probably have the most just. But at this point in time, we're in Massachusetts, and all of these people were insured. They all had what we call Mass Health, Medicaid. So it's not an uninsured group. And they're sitting in a little park that's actually on the grounds of the hospital where my appointment is, which is called Mass General Hospital. It's one of the big Boston hospitals, and arguably pretty good hospital. So they're fully insured, sitting on the grounds of our hospital. And when she showed me that picture 5 years later, I looked at it, and there was one of those people still alive. Their average age in that picture is 36, okay? And it hit us right between the eyes. As Al Story was mentioning before, mortality is probably the easiest thing you can measure, because it's hard to measure all things at homeless, but mortality is a pretty solid one you can measure, and the mortality rates are horrifying. So Jill Roncarati, one of our physician assistants, went and got her doctorate at the School of Public Health at Harvard, and this past fall published this paper, which was looking at a 10-year prospective study of people living on the streets of Boston. They were living on the streets in the year 2000. And to make a long story short, their death rate is 3 times that of people living in the shelters of Boston, which is already 4 times that of people living of the same age living in Boston. It's all age and rates, you can cut it out. But it's horrifying, okay? These are people living in the shadows of our great healthcare institutions in Boston. And they have what we now know to be the worst risk of premature mortality of any subgroup in America. And I would assume that's the same for any urban setting. So when we looked at the causes of death, turns out for people living on the street, much to our surprise, it was not suicide or homicide or hypothermia, it was cancer, cirrhosis, all the things that are kind of medically amenable conditions, if you can think. Now, of course, behind all of those is substance use and mental illness that it complicates it all. But I just wanted to point that out because we should have prevented a lot of those deaths if we had been able to, okay? Interestingly, we had very few overdoses. We're in the middle of an opioid overdose crisis in America, but particularly in Boston among our folks, but not on the streets, and I'll get on that in a minute. So this is just an example. This is a man who's in that picture. He's got a basal cell skin cancer. And I've Irish background, was a lifeguard as a kid, so I probably had 30 of those taken off at different times. I hate it. But it's a completely, fixable problem. And this man had this basal cell carcinoma, which I started seeing him in 1991, asking him, let's just fix that. We can take that off. And he said, no, I can pick it off. Don't worry about it, doc. And he's this really wonderful guy. I read a book a day, had some schizophrenia, was paranoid. But he eventually came to me about 3 years ago and said, maybe I better do something. And by this time, the basal cell carcinoma had gone all over his head. We had to bring him to the hospital. He spent 6 months in plastics after having surgery and a flap put in. And then this is visiting him at home. We got him into home, one of the housing first things after that. It's our team at one of our house visits. And he's now recovering from the surgery, but his basal cell carcinoma has become metastatic to his spine, and he died about 4 months later. He's the only patient I've ever had in my 40 years of being a doctor who died of a basal cell carcinoma. Totally preventable. So that's kind of the background I wanted to say. So back then we said, hey, I remember, never forget writing, this is 2005, we said, don't we wish as doctors and nurses and everything, we could just write a prescription for housing, because this is what we need with all the other services. We ought to just do this. So forgive me for that ancient slide, but it reminds me of how much hope we had in housing and how much we fought for that everybody should have it. And if we're going to do good health care for folks, that should be the foundation on doing it. So one of the things that came up, and this was a conversation before, is we're a team. I work in a team that takes care of people living on the streets, and we have about 400 or 500 people in Boston who live on the streets, despite the fact there's a shelter bed for everybody. And they're a really interesting subgroup of the homeless population. But as Housing First twisted the housing thing, as Jennifer said, so that these were now the people first in line for housing as opposed to last in line, they started to get housed. I've been doing this for 20 years, and no street person I knew had gotten housed except one accidentally got housed. So we started to say, oh, this is great. It's a chance for people to get into communities, and we can then get them sorted out in their communities. But this is Ellen Daly. On our board of directors, by the way, our program is now about a $60 million a year program and has 500 full-time employees. And on our board of directors, we have 5 homeless people of the 12 people or 15 people on the board. So they are literally the people that hire and fire us, and we have to get everything by them. But Ellen, I show this picture because she died not so very long ago, read us the Riot Act, because when people who had been on the streets that we've been caring for 20 years, all of a sudden got housed, we were then going to say now they can get into the mainstream system, although in many ways we were the mainstream system. But most of those people, what Ellen came back and said, if you've been our medical home for 20 years, just because I'm getting housed, you can't abandon us. So we got mandated by our board, the homeless people on the board, to follow people once they're in housing, to have continuity of care if they wanted it. So much of what I'm going to tell you is our experience now of doing literally thousands of house calls now each year to people that were on the streets for years now in their scattered site housing, and that's what I would say. So we were in 2005, part of a pilot in Boston, which we were the service provider, and we partnered with HomeStart, which is a housing program. We don't do housing, they do the housing search. It was a great thing. And at CSPEC, leave alone what is, but it basically was Medicaid in Massachusetts saying we're going to invest in housing services, which they had never done before. So in this pilot, which was a statewide pilot, but we had a small part of that, looking at rough sleepers. So this is the experience we've had now. It started in 2005, and we've been following these folks since 2019. I'm going to skip this because it tells you what it is. This is a housing first model, and it's essentially fidelity to what Jennifer said so eloquently, with the exception being that the money for it, some of the money came from Medicaid, which is pretty cool, the healthcare system doing it. And we followed the tenants, and I can give you the whole thing. The team that I work on has a full-time psychiatrist, a couple of internists like I am, or GPs full-time, a nurse practitioner, a social worker, and a recovery coach and a community health worker. We're all full-time, and our job is to take care of the people living on the street full-time. That's our panel of patients. And I would offer that because I think that's a secret that is missing from much of Housing First, that it's continuity of care, and your team has to be available 24/7 to make it work. Now, this is the first person we did, and I'm gonna go quickly over this because he's a guy who lived on the streets forever, slept on the sidewalks, 62, never been in a house. This was the first guy we got into housing. He's got the corner room right here. We moved him in. He was so thrilled, never had a house before. When he went shopping, this is what he bought, and we realized we had a huge issue trying to teach people how to be in housing if they've never been it before. It spent me a whole day going with him to get these 2 necessary pieces of ID, and I learned what the bureaucracy is like if you have no ID, how to get an ID, right? And you needed that to get all the benefits. Crazy. Now, and this was probably the most radical harm reduction thing I had. So this is a man who had been he has terrible heart failure, was in the emergency room at our hospital essentially every day, brought in by EMS in heart failure, and he would never take these medicines. So once we got him into housing, we could figure out with him, we had to visit him essentially every day, often twice a day, and get him to start learning how to take his medicines, which he did. He can't read or write, by the way. He lived on the streets forever and really had not learned how to read or write. Taught him how to do that, but his compromise was he moved used to have very low grade, what we call Popov vodka, and now he's drinking Stolichnaya vodka, because that's his compromise to being in housing. But he swigs his pills down with his vodka every day. So he has no interest in stopping drinking, but more than happy with a lot of things to take care of his heart failure. So he stayed in his housing for a year and a half, doing great. Never went back to the emergency room. He called me one night saying, I don't feel very well. By the time I got there in the morning, he was dead on the couch. But he died from arrhythmia, and something that you would have predicted was going to happen anyway. And he died in his own home, first one he ever had. And in many ways, we thought of that, even though it was a mortality, we thought it was a real success. Okay, so just to give you, that was the first one. This is what we learned to do. We do most of our primary care visits at home now. This is Jill, our nurse practitioner, our physician assistant who wrote that paper. We do, immunization. Everything you do in a primary care office, you can pretty much do at home. Okay, we even draw bloods and take them back. And we always go with mental health and diet. So this is our psychiatrist, Jim Bonner. So if I go do a home visit, it's somebody from medicine and stuff. So it's a lot of really kind of cool service. Problem is we have to take care of a lot of people, okay, and still the people living on the streets. So here's what happened. So if you look at the first 24 people, what happened is we were given 24 vouchers to take people right off the street. It took us a year to get those 24 people into housing. So the first year was getting people in. But then look what happened to them. If you say the retention among those first 24, there were 17 men, 7 women. 4 of them are still housed, just 4. Okay, and you go down, and just to let you know, most of them had to move 1, 2, 3, 4, and 5, and now tomorrow we'll have this one guy's going into his 6th apartment. Most of those moves were to avoid an eviction. So when we say only 2 people were evicted, there were probably about 20 almost evictions. So the statistics, when you read them out, are always a little tricky. And 14 of the 24 died. So our mortality rate in our Housing First was higher than what we saw on the street, which was already the highest we knew of anywhere. So this was what do you do? This is scary to us, right? And then if you, I'm gonna skip that because I don't wanna. So this is an example. So this is John. He was found almost frozen to death in this dumpster on a January several years ago. His body temperature was 58 degrees Fahrenheit. Somebody has to translate that to centigrade for me. But it was as low as anybody had ever seen. He we got him into the hospital. He went up to the cardiac operating suite, and they put him on cardiopulmonary bypass, and he actually lived and had very little, if any, neurological damage. It was the first time I'd ever seen that. And then he got into his housing. This is John in housing with the housing worker. And, and it was fabulous because he had lived on the streets for 25 years, has this event, comes to our respite program, and then we got him into this Housing First thing. And then we started visiting him because he was great. We would visit him, usually he ended up having pretty bad cirrhosis. We had to visit him several times. And this is him after about 4 years. And you realize that the taking care of people once they're in housing is sometimes more complicated than it was when they were on the streets. And the continuity of care became incredibly important. He was, like most street folks, not willing to go to the hospital or to appointments on any kind of regular thing, so we had to go to him, just like we did when they were on the streets. And so when we looked at the first 5 years of these 24 vouchers, and remember now they turn over, so in 5 years, 46 people used those 24 vouchers, okay, if you're with me on that. And look at this, after 5 years, a third of them were still in housing, okay? Only a third, all right? 50%, 23 of them had died, okay? And I can give you that 6 of them were expected, like cirrhosis with John, we expected him to die, we didn't expect him to live, but 17 were people that we had no thought that they were gonna die. So I used to think, oh, it's okay, we get high mortality rates in housing first because we're putting the most vulnerable people in there. But it turns out it's a little bit more complicated than that, okay? And then 6 of them are back on the street and 2 are actually in nursing homes, which is the most costly outcome we can have. This is an example. This is a man with AIDS. This is his apartment. He's got nothing in it except his wheelchairs. Doesn't take care of himself. We visit him, several times a week, just trying to make sure he has food and all that. But he takes a huge amount of work. Lived on the streets forever. Now he's in an apartment, but it's not the kind of apartment you and I would envision. And then this is Chris, who's with our nurse practitioner, and Chris was fabulous. He lived outside forever, the nicest human being you'd ever want to know, except when he was drinking, he'd get a little cantankerous. But he got in, and we did this, just to say, this was his cost before he went into housing, okay? Pretty staggering. And if you look at in 2010, I don't know how well you can read it back there, his costs go way down, and then by 2011, they're down to 0. Okay, so he's an example of the high risk, high user, gets into housing and the costs go way down. And we sort of said, wow, this is the way to go. However, this is what his apartment would look like when we get there sometimes, full of blood. This is all blood, okay? And we had to visit him. He'd do well for 3 months, and then all of a sudden we'd have a crisis. He'd do well, he's been in housing now for 12 years, and it's been like this, almost out in backing out. So it's a huge amount of work. And anyone who tells you that people get stable after 3 to 6 months and you can back off on your services, if you're talking about chronic risk leavers, is wrong. Okay, it's got to be flexible, and they're gonna be fine for a while, but then things are gonna happen. Whatever drove people to the streets in the first place does not go away when they get into housing. Okay, whatever the demons are, and I say demons loosely because that's what one of our homeless persons describes it as, they come back up, they come back to haunt them, and they need a lot of support. And I'm worried that in all of our programs, we don't provide that support, or we provide it too briefly, too short, and then you end up with outcomes like this. And this, remember, is a program where we're still visiting him we have psychiatry, medicine, nursing, social work going to visit this person a couple times a week. Okay, and he has a housing worker paid by Medicaid to do it. So there's a lot of service going there, just not enough. And now, the last thing that's haunting us now is this is Donna, lived on the streets forever. She's fabulous. She got housed in her own, she was able to use her check to pay for a relatively inexpensive apartment in Dorchester, gets housed. This is her coming to clinic, and then she got diagnosed 7 years after she's in housing. She comes in and she's not feeling well, can't move her arm, and she has stage 4 lung cancer and is basically going to die in a few months. And we did all of our care at home. This is her at home with her boyfriend in her apartment, which she was very proud about. She got a job, she was driving, but she got this cancer, and about a week after she got this cancer, the building was sold by the owner because they wanted to upgrade it, and everybody was told you have to leave in the next 30 days, or you can buy the apartment because it's now going to be condominiums, which she, of course, can't do. And so she was evicted, okay? And this is her 2 days before she died, coming back to the streets with her boyfriend. This is our little park where I showed you that first picture. And so she's now homeless and dies homeless, okay? And interestingly, in our country, you have to be homeless now a year before you're eligible for housing. So she had been housed for all that time, and she had to start from zero. So I thought of this as the greatest failure for all of us, because she was getting the best of care for her cancer, but we couldn't keep her in housing. It was kind of interesting. So I want to end by saying this is what's troubling me, and I throw this out as a discussion for you guys. So I was part of this National Academy of Sciences it's a National Academy of Engineering, Medicine, and Sciences of the US. That's our main thing for looking at big problems, right? And I was part of a panel. I think I was a token sort of doctor on the panel or something, but it's all heavy-duty researchers, all people you would recognize, all people that do homelessness research, but then a lot of just pure hardcore researchers. We looked at all the evidence that exists in the world. This is what I'd love to talk to all of you about. And if you take a researcher's point of view, as opposed to an advocate like I am, because our question was, what is the evidence that exists that shows permanent supportive housing for chronic homeless people now, not even rough sleepers, just chronically homeless people, either saves money or or improves health. And I thought it was a slam dunk, okay? And it turns out there is, and this was a conclusion that was published last July by the Institute of Medicine. Unfortunately, as they would say, except for small things in HIV and AIDS, as Jennifer pointed out, where there's a very little bit of thing, okay, there is absolutely no evidence right now that permanent supportive housing improves health or saves money. In fact, most of the evidence that's out there shows that people in poor housing have poor outcomes. So we have to be really careful. New York City right now in the public housing where we put every people is turning out to have terrible health problems. So we have a huge amount of work to do, trying to figure out, and I would take the opposite. I think this is something where we really need to study it carefully. The problem, the thing that I made the mistake of, and I think most of us do, is almost all the studies are pre and post studies. You take 100 people, you put them into housing, you look at their costs last year and you look at their costs this year, and almost everybody shows a 70 to 80% savings in costs, right? Turns out, when you do randomized trial, if you take 200 people, put 100 in who are high users and costly, put them in housing, you put 100 in housing randomly, and the 100 you don't, turns out the same savings are there. So housing has nothing to do with that, or maybe it has a tiny bit to do with the savings. And I think I certainly have bought onto there is clear evidence that housing people saves money. And I think Jennifer was hinting at this. It's not very clear at all. What we have to do is work on doing things like finding out what kind of housing works, what kind of services do different people need, and we have to fund that. To conclude, just to let you know, I think I had this was the $1 million worry thing. I think it set us off, certainly in America, on the wrong path. You do save a lot of money on $1 million worry, but there's an awful lot of people who have been outside, you house them, and all of a sudden all their health problems come, and you end up sending them to the hospital and sending them to the clinics, and they cost a lot of money. So it's a very tricky little thing. And then if you look at, this was Sam's Pathways to Housing thing, which Jennifer also mentioned. And if you really look at it, it was a fabulous program targeted to chronic mentally ill folks on the streets of New York, most of whom were not drinkers, okay, and most of whom were kind of solitary. And when they got them into housing, which Pathways to Housing owned the housing, or it was a leaseholder for the housing and the payee, it worked, okay? But you know what the service model was? It was an ACT team, okay? So it was an ACT team, meaning a full-time psychiatrist, a full-time nurse practitioner, full-time, I don't know whether LICSW makes sense in England, or what's a social worker who's licensed, LICSW, a full-time peer worker, a nurse, and a community support worker. That full-time team had a limit of 45 people that was their entire work. So in our country, this has never been duplicated, okay? No one's been able to give that kind of support. So we have our team, we have about 350 people we're trying to take care of at home, in addition to people living outside. We should be limited to 40 or 45, and then we might make a difference. So I would never let go on how important the services are. I think we look at the first-year outcomes or the second-year outcomes of housing, it looks pretty good. But if you look at the 5 and 10-year, it starts to look like deinstitutionalization results from the old days, okay? And I think we just have to be aware of that. And I think that's it. I think, this is the last thing I'd say is, I'm getting a little nervous, and this is my own bias, in our own hospitals now thinking of investing in money because it's gonna save money to the hospital. And it turns out it doesn't save money to the hospital. And what they're gonna do is take healthcare dollars and put it into housing at a time where we don't have enough money for dentistry or psychiatry or all the things that people really need who are currently homeless. And the last thing I would get to, where the money should be coming from in our thing is HUD. Our government got out of funding poor housing, and I hate to have hospitals fill in that funding gap. That's what I'm nervous about. But the last thing I just share with you, and this is just another thing to be provocative or something, the social determinants of health are really what's at play here. But the social determinants of health for these rough sleepers happened when they were 9, 10, and 11 years old. We didn't provide good foster care. There was no good school system. They lived in dangerous areas. And so now that they're homeless 40 years later and on the streets, we're not doing any more social determinants of health. It's already been determined, okay? And what we're trying to do is figure out what are their health and social service needs now. And I would be careful to not confuse those two things, Because we need food and transportation, everything for these folks, but we're not changing homelessness by doing that. The only way we're going to change homelessness, in my opinion, is if we start to fundamentally change our school system, our correction system, you name it, our labor system, all of those things, because homelessness is actually the failure of all of those real hardcore social determinants of health. And we're stuck way downstream taking care of people as best we can, and in ways that I can't believe how remarkable are done around here. And that's where I would kind of leave it. It's an open question that I would urge you to keep thinking and keep an open mind about. Okay, thank you. Okay. I hope I didn't go over.
And that's a really great question to finish on. And I wonder whether there's any comments from the floor, because it's so fundamental. Stan at the back, any other people? So we'll take 2 or 3 at a time. That gentleman over there, and here at the front. Yep, go ahead, Stan.
Great. It's always great hearing you. You put some economic stuff up there, and I think that's where some of the issues lie, both where you are and where we are, is that there's too much emphasis put on the financial cost, and there's not enough stress actually put on the cost of the person, the individual. And perhaps, are there, in your opinion, ways of measuring outcome on individual rather than input financial? Because that's where the benefits lie, really, by improving people's health and their outcomes.
Thank you. And that gentleman over there, can you say who you are?
Hello, I'm Terry Hitchcock. I'm the chair of Groundswell, which is, as some of you will know, is a homelessness charity where the services are delivered by formerly homeless people who volunteer to do that. Brilliant and fascinating talk. Thank you very much indeed. I'd just like to pick up, though, on one thing you said in passing. We have one member of our board who has lived experience of homelessness. We try to have 2 or more. We're very keen that our decisions are based around and taken with the active support and encouragement and advice from people with lived experience of homelessness. So I was really interested when you said that your board, I wasn't sure whether it was all of them who have lived experience of homelessness or some of them, but anything you can share with us on the experience of that, how they're recruited, how they're retained, how they're trained, I would be really very interested to hear that. Thank you.
Thank you. And the third question.
You should be challenging me, by the way. I'm trying to be provocative so you can challenge back, okay? But I can certainly, let me answer in reverse. Oh, I'm sorry, there's more. Excuse me, I'm sorry.
Sorry, it was just comments really. Mayday Trust. I think it's brave to say it doesn't save money, because I think always with new ideas, there's always a pressure they've got to save money in the public sector in the UK. If you come with a new idea, you've got to prove that it saves money at some point. So I think it's brave to admit actually probably wouldn't. And I think, just to comment on the 34% people still in accommodation, I think that's amazing. To say that it didn't sound great, I think actually from where people started, like you say, when they were 9, 10 years old, that's amazing that that many people managed to still be somewhere.
Just to let you know that 30% includes people that were just housed within the last, so this is an ongoing study, so some people have been housed less than 3 months. So what we don't know is if you just froze it, what it would be down the line. We know of the first 24, only 1 is still housed now. So it's tricky. I think we just don't know what happens, and my fear is nobody's really looking, we tried to find studies looking at long-term outcomes, you can't find any. Yet we're putting a massive amount of effort into doing something. I just want to learn how to do it better. We're desperate where we are to learn how to do it better because we feel like we failed in most of our stuff. I think what we did, and this answers one of the other questions, is I think if you talk to the people we take care of, they would say that the quality of their life was way better because they had people in their lives that were there with them all the time. And so when they got sick, we have full access to the specialty service. We have, we're part of the hospital as well, so we have the full hospital. And people are really grateful for that, even though it's a march toward death if it's cancer, right? But then if I go back to the financial arguments, which I think we in America, we use the financial argument because no one would pay attention. And $1 Million Murray was a New York article that made people say, whoa, maybe we can save money if we put thing into housing. And it was a fabulous advocacy tool, which I got totally behind, because you couldn't get anyone's attention. But then as we got further into it, you start to realize you know, if it's cancer care, nobody says, is this a cost-saving medication? You would just say it's something we need to give people because they deserve good care. And I wish our country would say, these are people who were devastated by the way we set up our social systems. And now that they're sick and need care, we should pour money into it the same way we would to a war, you know, and not ask people, what's the return on your investment? You should be looking at what's the quality of their life and stuff. So that would be my argument. That doesn't, when somebody's elected for 2 years to Congress, they don't care about that. So that's the downside of everything I'm saying. We have to find a better way to talk about how housing is a right. And I mean, as we all know, fundamentally for most homeless people, to house them is going to cost us money because they're just normal people. They just need housing. You have to invest in that. You don't save money. So I think that kind of an argument is what we're trying to do. The other, so it's a moral argument that doesn't, as I'm looking down at you back there, it is the moral argument. It's a little tricky to make that argument in this day and age. So I totally recognize that the need but this is a case where research and advocacy are going in different directions, and I don't know how to reconcile those because I'm an advocate at heart. But I also, in medicine, you really look at the evidence, and the evidence that I thought was there probably isn't really there. So we have to find a better way to talk about it. It's a long discussion about the homeless people, but I didn't know if I made it clear, but when we got put together as a program, it was a grant given to the city of Boston, and it was a requirement that the stakeholders be involved in designing the program. I was still a resident, so I had nothing to do with this, but homeless people were involved from the beginning. And for example, our respite program we started in September of 1985 because the homeless people said, damn you hospitals, you're discharging us, we have no place to go, you have to come up with some place to put us. And so we started in a shelter with a respite program back in 85 and had to, but that was all started by homeless people. The continuity of care concept was all homeless people saying, we're not interested in volunteers coming out and charity, we don't want charity, we want consistency, we want someone who we know is going to be our team or our doctor or our nurse, and you will be here for us. That was the challenge. And in those days, I was only going to do it for a year. I wasn't going to do, this was my year of doing good, and I was going to go on and do my career. And I got caught right in the middle of that. They said, man, after we spent all this time getting to know you, you're going to now say I'm going to do my career and desert us. So that became part of that. But getting homeless people, what we had to do is we had to spend a lot of time on this, inviting homeless people from like families and people on the street and other people. So you get different, we have a huge transgender core and a HIV core. And so they get together once a month. We pay for it, have a big meal. They talk, we stay out of it, and then they plan. And from that group, they elect 5 people to our board of directors, which then have fiduciary responsibility. But that's been going on since 1986, and it's a journey. Doesn't happen overnight. And you have to cultivate and really support, because I should have shown you a picture of our board of directors, but 4 of them died last year. So mortality is still among that group. So just after they've been doing all this, then you lose 4, and it's devastating, because they've been really a part of the program. So now we're gearing up again to do that again. So it's a challenge, and I'd love to talk to you about what we've been through if you got a second. Okay.
Any final burning questions? One more, any others before we wrap up?
Hi, I'm Kelly. I'm an occupational therapist. Recently joined the King's Health Partners Homeless team. And I'm really interested about your comment about you said, whatever the reason for someone becoming homeless, it doesn't go away when they're housed. And you said, quite rightly, that children who aren't given those opportunities to learn those kind of independent skills, or as they grow up, they don't have those opportunities to learn how to live independently, how to manage daily tasks and things that keep people well. And I'm interested about if there are any provision for rehabilitation facilities, or that the idea of helping people to develop those skills, because it's not just about their physical health and maintaining that, but it's also about actually helping them to manage those tasks involved in owning a house or looking after a house and looking after themselves. And just wondering what your kind of thoughts were on that.
My thoughts are like many of the supports we have, the things we really need desperately, we don't do very well, are work experience programs, sheltered work programs, ways to improve people's incomes. And then there's a lot of stuff we don't. We have, for example, a physical therapist comes with us and does physical therapy at home, but we really need to, it needs a much bigger thing. But finding funding for that is really tough, because this is a really needy population. But I would say did you say you're a physical therapist? I'm sorry?
Occupational.
Oh, occupation, well, even better, okay? Because in our respite program with 104 people, it's like what they all need is OTPT, we would say. That's what they need. They need some good medicine and some psychiatric care, but OTPT is what really helps them most. And trying to get that paid for in our country is really difficult, but a screaming, screaming need. So if you could do something to look into that, it would be huge.
I'll try.
Okay. Thank you very much, and I'm sorry to be a little provocative
Thank
there,
you
but
so
I'm all
so
for
much,
that.
Jim. I think we'll leave it there.